Hello, I want to thank Breas for his invitation to talk about deventilation syndrome. This syndrome can be studied and is frequently seen in COPD. I will show you the current data available in today's presentation. Here are my conflicts of interest. So here is the agenda for the presentation. Firstly, what is deventilation syndrome and do we have prevalence data? Is deventilation syndrome only in COPD? What are the clinical characteristics of patients who present a deventilation syndrome? What is the impact of the deventilation syndrome in COPD? I will start with the pathophysiological mechanisms involved in this syndrome and finish with the therapeutic strategies that are currently available. Deventilation syndrome is when dyspnea is present in the morning when NIV is removed. There is no consensus definition in terms of intensity of dyspnea. There are 3 published studies on this syndrome. In the first, by Adlers and co-workers in 2012, deventilation syndrome was defined as a dyspnea on a Borg scale of greater than 4 out of 10. In more recent studies, by Schellenbergs and co-workers defined deventilation syndrome as the increase in the intensity of dyspnea by more than 2 points on the Borg scale in the first 30 minutes after removal of the mask. Lastly, Lutgens and co-workers, the dyspnea was defined as a worsening of dyspnea after removal of the mask, with an increase of more than 3 points on the Borg scale. You see that the intensity varies depending on the studies. Regardless, this intense dyspnea will interfere with the patient's activities of daily living and often associated with tachypnea and the need to sit down to improve ventilation. So this syndrome has been rarely studied. We only have 3 studies that report prevalence. The Adler study, prevalence in the COPD patient cohort, 61 COPD patients were studied in this study. Of these, 32 patients had severe COPD. He removed overlap syndrome with a sleep-type apneic syndrome, and see that there were 9 ventilation syndromes out of 32, a prevalence of 28%. In the Lutgens study with a fairly identical cohort. See 31 COPD patients. Remember, there is a prevalence of 36% since 11 out of 31 patients have a deventilation syndrome. In Schellenberg's study of 71 patients, 3 were excluded. In fact, 4 patients were excluded, 1 because it had been included 2 times in the study. 3 since there was no rating of the dyspnea, so on 67 patients this time, 39 patients with a deventilation syndrome, a prevalence of 58%. What are the characteristics of these patients with deventilation syndrome and what differentiates them from patients without deventilation syndrome? In terms of clinical features on sex, age, or BMI, you see that there is no difference. Particular on the inspiratory and expiratory pressures, again no difference with levels of inspiratory pressure in particular which are identical. The respiratory backup rate is not different. On the other hand, you see that the maximum inspiratory time is discretely longer in patients who have ventilation syndrome than in patients who do not. In terms of severity on alveolar hypoventilation, there is no difference with a PCO2 around 47 mm of mercury. On respiratory function, we see that patients who have a deventilation syndrome have a decreased VC max, probably related to diaphragmatic involvement. We will come back to this later on. They also have a more severe bronchial obstruction. These patients have a more important respiratory functional impairment and they have chest distension. In any case, a gas trapping attested by a RV report on TLC more alter since the RV is more increased then it is not significant, probably because of a lack of power, but an inverse on TLC more increased testifying to a greater gas trapping thus causing a static thoracic distension. This chest distension and gas trapping are related to increased bronchial resistance. Moreover, this ventilation syndrome has an impact. We will come back to muscle performance because you see that the walking distance is significantly lower in patients with deventilation syndrome than in patients who do not. But you notice that these patients have severe respiratory involvement with severe obstructive ventilatory disorder. When we look at the other German study with a higher prevalence of ventilation syndrome, I remind you, 58% of patients have a deventilation syndrome. Compared to patients who do not have a deventilation syndrome, we find a higher smoking, probably causing more severe COPD. We will discuss this later. There were no other differences in terms of clinical characteristics, either BMI, age, or sex of patients. There was also no difference in terms of drug treatment. When we look at the pressures, we will come back to it, but you note that the levels of inspiratory pressure are higher than in the previous study, but no difference again between patients who have deventilation syndrome or patients who do not. This time, the backup frequency is not different, but this time there is no difference in terms of maximum inspiratory time. Patients who have deventilation syndrome are more severe with a greater flow of oxygen needed than in patients who do not have deventilation syndrome, so again probably a more severe respiratory involvement. And indeed, when we look at the severity of bronchial obstruction, we have a significant difference with very severe bronchial obstruction in patients who have a less severe deventilation syndrome in patients who do not have one. This has an impact on dyspnea and quality of life since CAT score and MRC score are higher in patients who have deventilation syndrome than in patients who do not. When looking at the level of chest distension, see the percentage of residual volume. There is no significant difference, but still, we see that the residual volume and larger, higher in patients who have a deventilation syndrome with significant thoracic distensions. When we look at the diaphragmatic excursions, witness of the diaphragmatic function, there is no difference in pre-ventilation, so just before the patients are put under NIV between the two groups of patients. It had been seen that patients had higher levels of oxygen therapy. They also have a greater alveolar hypoventilation in this, whether before NIV, it is the patients who were seen as part of the follow-up of their NIV, so patients already fitted for a while, and we see that, whether before NIV or withdrawal of NIV, a significant difference in terms of alveolar hyperventilation, so probably still more severe patients in the deventilation syndrome group. Now, if we try to understand what differentiates the two studies within the Schellenberg study, a prevalence of 32% and in the second study a prevalence of 58%, what we find as a difference is on the one hand the level of pressure. So there is no I cannot do statistics because it is two different studies, but you see that in the first study, the inspiratory pressure level is at 16.7, so in the second study, the inspiratory pressure level is more important, 21.5. The maximum inspiratory time and also discretely higher in the second study compared to the first, and finally the level of bronchial obstruction is also a little more important in the Schellenberg study. There is however no difference in terms of chest distension. So what impact will the deventilation syndrome have on patients' quality of life? You see that patients have a deventilation syndrome, we see by definition have a more important dyspnea. But we also see that in terms of quality of life assessed by the SRI questionnaire, there is a significant difference with a more altered quality of life in case of a deventilation syndrome compared to the absence of a deventilation syndrome with greater respiratory complaints. A more important functional impact on physical performance. This is confirmed on the measurement of the 6-minute walking test. You see that, after removing the mask, there is a significant decrease in walking distance to the walking test of 6 minutes. We also have a decrease in maximum vital capacity indicating an increase in diaphragmatic weakness most likely. While in patients who do not have deventilation syndrome, there is no difference in the walking test, there is a decrease in vital capacity but which is not significant. So finally, patients who have a deventilation syndrome have a significant decrease in the intensity of dyspnea after removal of the mask, an impairment of functional performance with a decrease in walking distance of 6 minutes. No change on the other hand, no significant differences in terms of partial pressure of carbon dioxide, ventilation was effective in all two groups. In the Lutgen study we see the evolution of dyspnea. You see that dyspnea remains significantly higher with a score around 7 on the Borg scale, and this increase in dyspnea persists significantly for 2 hours. Afterwards, the patient finds a higher dyspnea than in the group of patients without deventilation syndrome but with a stabilization of the intensity. In terms of vital capacity, Patient without deventilation syndrome has a vital capacity that remains stable, while the patient who has the deventilation syndrome has a significant decrease in vital capacity that improves after 2 hours. This probably explains this decrease in walking distance of 6 minutes, which improves significantly after 4 hours. On the other hand, there is no significant evolution of PCO2. You see here in the Lutkin study, the evolution at 10 minutes of the removal of the mask, at 20 minutes, at 30 minutes, and at 60 minutes. You see that compared to patients who do not have deventilation syndrome, there is a significant increase in dyspnea after 10 minutes after removal of the mask in patients as a deventilation syndrome, and that this dyspnea at 60 minutes is still higher even if it is no longer significant for patients who do not have the deventilation syndrome related to respiratory involvement more severe. When we look at the respiratory rate of patients with a baseline NIV and withdrawal of NIV, we see that patients have a deventilation syndrome have a respiratory rate that rises at withdrawal of NIV while it is well improved by NIV, and that respiratory rate is higher, even if it is not significant either at T1 or T2 compared to patients who did not have no deventilation syndrome. So what mechanism can we evoke at the origin of this deventilation syndrome? We can talk about asynchronous. In the Dan Alder study, we see that when we correct asynchrony, the deventilation syndrome decreases, and these asynchronies are mainly related to unrewarded efforts. In this study, when the clinician saw unrewarded efforts, it was accompanied by a reduction in inspiratory pressure. And this allowed an improvement of the deventilation syndrome by improving the number of unrewarded efforts. We had in a few patients an increase in the respiratory backup rate, you see, but without effect on the spontaneous frequency of the patient, since almost all the patients, the patient's frequency was higher than the backup frequency. When we look nevertheless in Schellenberg's study, we do not see significant differences between the levels of inspiratory pressure between the two groups of patients, whether or not they have a deventilation syndrome. Similarly, the backup frequency was not different. There was no difference in this study on the duration of the maximum inspiratory time, but there was a duration of the maximum inspiratory time that was a little higher in the Lutkin study, probably indicating possible late cycling. We can evoke a diaphragmatic weakness since the maximum vital capacity was decreased after removal of the mask. Nevertheless, in Schellenberg's study trying to look for an increase in diaphragmatic dysfunction by diaphragmatic ultrasound and measurement of diaphragmatic excursion, you see that in the two groups, there was a decrease in diaphragmatic excursion, but there was no significant difference between the two groups. Nevertheless, this reduction in the diaphragmatic excursion could testify to a transient decrease in the diaphragmatic force due to hyperinflation, as also evidenced by the reduction in vital capacity, which was on the other hand more important in the syndrome of ventilation, as well as the measurement of maximum inspiratory pressures. Probably the deventilation syndrome will come back to it results from diaphragmatic weakness or fatigue that cannot be seen on diaphragmatic ultrasound in connection with dynamic hyperinflation caused by ventilation. Indeed, this dynamic hyperinflation is accompanied by the fact of the positive alveolar pressure at the end of inspiration of an additional inspiratory load on the diaphragmatic muscles, and if the diaphragmatic muscles, the other inspirating muscles, cannot fight against this override load, then occur the unrewarded efforts. Indeed, in COPD patients, we see this dynamic hyperinflation with a very late return of expiratory pressure to zero, with an effort here of the respiratory muscles to trigger the ventilator. The other element that can promote this dynamic hyperinflation is late cycling, as evidenced by this study of the somno-VNI group, or late cycling can be accompanied by passive insufflation. That is to say that the patient waits to pass to the expiration, waits at the end of pressurization to pass to the exhalation, or the patient can make an expiratory effort that we see here on this Parthasarathi study, or the patient makes an expiratory effort with the contraction of the transverse muscles, which is seen here with a pressure peak that is also found here on the pressure signal. And so if cycling is delayed, the expiratory time here is decreased, and therefore dynamic hyperinflation then occurs. The other element that can promote dynamic hyperinflation is the reduction of expiratory time. When to show here by Laurent Brochard in patients. So this time's COPD, but in acute respiratory influence, ventilated in intensive care, or when the patient has an increased respiratory rate. Here at 19, we have a reduction in expiratory time that does not allow pulmonary emptying and therefore what is associated with a positive pressure at the end of exhalation, an auto PEEP. When the respiratory rate is slowed down this time, the expiratory time lengthens, allowing a total pulmonary emptying. So finally, if we want to summarize in COPD, the pathophysiological mechanisms of deventilation syndrome. This results from a diaphragmatic weakness related mainly to unrewarded efforts, so to the efforts increased by the failure to trigger the ventilator in connection with dynamic hyperinflation, that is to say dynamic hyperinflation, can result either from a high current volume, or from an insufficient expiratory time. The high tidal volume is related to too high inspiratory pressure. As we saw in the study of Schellenberg, or insufficient expiratory time that can be related to cycling too late, sometimes related to a maximum inspiratory time too important, or at a spontaneous respiratory rate of the patient too important, which can result this time from insufficient inspiratory pressure. This insufficient inspiratory pressure also directly induces diaphragmatic fatigue since the diaphragm and extra-diaphragmatic respiratory muscles are forced to make an extra effort to ensure proper alveolar ventilation. So finally, this diaphragmatic weakness at the origin of the deventilation syndrome can be seen in two pathologies other than COPD. They are then clinically encountered in patients who have neuromuscular pathology evolves with severe diaphragmatic dysfunction, but there is no literature in this area. It is really the clinical experience where we find this syndrome of deventilation that can be linked, on the one hand, to the fact that the inspiratory pressure is too high, and this inspiratory pressure too high is accompanied by a reduction in the central control. So in neuromuscular patients who receive ventilation, we must first ensure that patients are not too ventilated at night by nocturnal capnography. But in the vast majority of cases, it is not an excess of inspiratory pressure. These are patients who have difficulty restarting spontaneous ventilation because of an insufficient drive or especially a significant diaphragmatic dysfunction. And then some patients are very sensitive to changes in positive pressure ventilation brought by NAV versus negative pressure in spontaneous ventilation. Often these are patients who have high levels of pressure. So how to fight against this syndrome of deventilation essentially in COPD? Since this is where this syndrome is most prevalent, we must first fight against hyperinflation, first of all by optimizing inhaled bronchodilator treatment to fight against static hyperinflation. And then, if the patient has too high volumes, this is what we see in a number of some COPD in particular. We saw in Dan Adler's study. In these cases, it is necessary to reduce the inspiratory pressure. If we have arguments for late cycling seen on the night recording, on the reading of the waveforms, we must increase the sensitivity of the cycling. If the patient has tachypnea due to a low tidal volume, we see patients who are very tachypneic, and in these cases, if they are very tachypneic, they have an expiratory time that is insufficient and therefore no time to empty their lungs. At this time it is necessary to increase the inspiratory pressure to reduce this tachypneics. And then if we cannot correct this intrinsic PEEP, we can increase the expiratory pressure to reduce the inspiratory effort of the patient to fight against this intrinsic PEEP. A German team, always the same, Junger and Lutgen, tried to reproduce the pursed lip ventilation that COPD patients spontaneously undergo in spontaneous ventilation when they have hyperinflation, and therefore in this ventilatory mode, the expiratory pressure at the beginning of exhalation increases to fight against this intrinsic PEEP, and then goes back to a pressure level identical to conventional BiPAP ventilation. And so the objective is to try to reduce the unrewarded inspiratory efforts due to this hyperinflation by doing this lip breathing pinched by an initial increase in EPAP at the beginning of exhalation. They prospectively evaluated this ventilatory mode in patients who had a deventilation syndrome, and you see that thanks to the decrease in unrewarded efforts, they were able to significantly decrease inspiratory pressure without increasing alveolar hypoventilation and thus improve inspiratory muscle performance. You see that the VC increases significantly and they have thereby improved the deventilation syndrome. Well, they have not corrected totally, but they have improved it on the Borg scale rating at the removal of the mask. And finally, If all these modalities are a ventilatory modification, then pursed lip ventilation, there is only one study that has tested it on few patients in retrospect at first, but prospective in a second time. But it is not a ventilatory mode that is available. And so if the deventilation syndrome persists despite the correction, the attempt to correct dynamic hyperinflation and unrewarded efforts, or if the patient is sensitive to the transition from positive to negative pressure, we can try the degressive ramp that is proposed by different manufacturers and in particular by Breas on the Vivo 123. This decreasing ramp can be set between a duration of 10 to 60 minutes if it is activated at intervals of 10 minutes. In these cases, the inspiratory pressure will gradually decrease until reaching 2 cm above the EPAP or above the beginning of the ramp. So, to conclude, deventilation syndrome is defined by an acute morning dyspnea when NIV is removed. It has a large clinical impact on dyspnea, quality of life, and also on physical performance, with patients having a walking distance reduced on the 6-minute walking test, overflowing to impact on activities of daily living. Prevalence is important. It ranges from 30 to 58% in COPD patients with very severe respiratory involvement and who basic static hyperinflation. This static hyperinflation is aggravated by NIV, with dynamic hyperinflation that can be caused by ventilation levels, high inspiratory pressures, and/or delayed cycling. Deventilation syndrome is related to diaphragmatic weakness, and if we cannot correct the ventilatory parameters, we can try a degressive ramp to help the diaphragm gradually move from supportive ventilation to spontaneous ventilation. Thank you for your attention.